And let me start by thanking the Drays again for their generous support that allows this program to go on. I don't recall that you were able to make it in for the July session, so I'm delighted that you can make it today. And for those fellows who weren't on board earlier in the year, the Drays have both had long-term relationships with the School of Medicine, and we're very grateful to them for the ability to have folks like Dr. Badano teach us. So Dr. Badano is the professor of cardiovascular medicine at the University of Milano Bicocca, and he directs the multimodality imaging laboratory at the Istituto Oncologico Italiano in Milano. Luigi, please forgive my Italian pronunciation. Luigi, as I recall, is from Northern Italy. He received his MD from the University of Parma and his PhD from the University of Padova. Had staff positions early in his career, briefly in Genova, Aviano, and Pordenone, and then faculty positions in Udine, Padova, and for the past 2 years in Milano. So if you're interested in learning some Northern Italian geography, just follow Luigi's career. He's got wide research interests that all have focused on various aspects of cardiac function using advanced echo methods, particularly three-dimensional echocardiography, where he is, from my perspective, one of the world's leaders in that field. The CV lists 290 published papers or papers published in peer-reviewed international journals, another 80 in national peer-reviewed journals, 9 books, 75 book chapters, and a Scopus H index of 67. As some of you will know, that's a measure of productivity and impact, and 40 is considered excellent, 60 is considered exceptional, and Luigi is above that mark. He's the associate editor of 4 journals, on the editorial board of 10 more, served as president of the European Association of Cardiovascular Imaging between 2010 and 2012, and is an honorary fellow of the EACVI, ASE, and the British Society of Echo. He's given more than 1,000 invited lectures and organized over 50 international seminars and training courses. But I think most importantly, he's a good person, a good father, and a good friend. So I'm pleased to introduce Professor Luigi Badano as the 4th Dray Virtual Visiting Professor. He's going to discuss today the echocardiographic assessment of left atrial geometry and function in 2021. Luigi.
Thank you, Alan, for your nice word. You are just remembering me how old I am. And let me also thank you, Mr. Ugo and Mary Hannah Dray, for supporting this educational opportunity, and particularly the University of Washington for this invitation. I am really honored and pleased to be with you today. So, how to assess the size and the function of the left atrium? The first question for any echocardiographer would be, why bother about the left atrium? And there are many reasons, but the 3 most important that I found are listed in this slide. First of all, because the enlargement of the left atrium or its dysfunction is bad for the patient, because either it means that LA pressure are elevated, or the wall of the left atrium is affected by any disease. For example, the most common is the fact that the diastolic dysfunction of the left ventricle affects primarily the left atrium. An enlarged or dysfunctioning left atrium increases the risk of atrial fibrillation, and you know that these arrhythmias carries morbidity and mortality to our patients, and particularly independent of the presence of atrial fibrillation. An enlarged left atrium carries a worse prognosis in various cardiac conditions. This is not new. I am presenting this seminal paper by Teresa Zhang that was published at the beginning of this century. In this paper, she found that not only an enlarged atrium is a powerful prognostic predictor in a variety of clinical conditions, and the list that you see here on the left of the slide is only a partial list of those conditions. But she also was able to show a gradual increase of the risk by the increase of the size of the left atrium. Why bother on the left atrium? Recently, and just a few weeks ago, the European Association of Cardiovascular Imaging issued the guidelines for diagnosing heart failure with a preserved ejection fraction. And in addition to the usual parameters that are included in the workflow for the assessment of the diastolic function of the left ventricle, so the tricuspid regurgitation velocity, the mitral flow velocity of the E and the A wave, the mitral annular velocity, for the very first time, the reservoir strain of the left atrium has been included as a main parameter that when is reduced, and particularly reduced below the level of 18%, is a powerful predictor, and we will see more about that. An enlarged left atrium is also one of the reasons why you have to send a patient to be evaluated for surgery in a patient with organic mitral regurgitation. When you have a patient who, even if he or she is asymptomatic, but with an enlarged atrium, and particularly when the left atrial volume index is larger than 60 milliliter meter square, this is a 2A indication for mitral valve surgery. I have to underline that this indication is present in the guidelines issued by the European Society of Cardiology, but it's not in the ACC/AHA guidelines for the treatment of heart valve diseases. So it's important to evaluate the size and the function of the left atrium, and it's important to do it in the right way. For those who are interested in going deeper in this assessment, I can just recommend this recent review paper by Liza Thomas and several colleagues from around the world that reviews in detail the tips and tricks to measure both the geometry and the size of the left atrium. Just to summarize, we have measured different parameters over the time. We started with the M-mode diameter, anteroposterior diameter of the left atrium, that was soon replaced by the 2D guided anteroposterior diameter. Then we moved to the area of the left atrium obtained from the apical four-chamber view, and then finally to the volumes of the left atrium, either calculated using the apical four-chamber and the two-chamber view, or actually measured by a 3D dataset, as we will see. And all of these different parameters describing the size of the left atrium have been reviewed, critically reviewed in the last review of the cardiac chamber quantification that was jointly issued by the American Society of Echo and the European Association Cardiovascular Imaging Association in 2015. And one of the main point was to defining the M-mode anteroposterior diameter of the left atrium obsolete and not anymore a reliable parameter of the left atrium size. There are many evidences for that. I can just show you one of the studies that we produced about that. Here you have the different classification of normal, mildly dilated, moderately dilated, and severely dilated left atrium using 3 different parameters. One is the M-mode anteroposterior diameter. The other is the reference that was the 3D volume divided by the body surface area, and then also the M-mode diameter normalized by the body surface area. Just let us just concentrate on the left part of the slide. So the comparison of the M mode with the actual 3D volume. And you see that when you use the M mode, you really underestimate the size of the left atrium. And so you overestimate the rate of normal subjects, and you grossly underestimate the number of patients at risk that are patients with severely dilated left atrium. And there are also anatomical reasons for that. And the main reason is the particular position of the heart into the chest. You see that the atrium is confined between the sternum anteriorly and the spine posteriorly. So when the atrium dilates, there is relatively limited space in the anteroposterior dimension, while there is much more opportunities to dilate in during the anterosuperior direction. Not only, but when the atrium dilates, it also changes the shape. And so if the normal atrium can be assimilated to an ellipsoid, a rotational ellipsoid, when the atrium dilates, become more similar to a trapezoid. So the same geometrical assumptions that we use to calculate the volume of the normal atrium are not necessarily valid when the left atrium is dilated and it changes its shape. So this is why both the anteroposterior diameter measured with the M-mode echocardiography or 2D echocardiography are not considered anymore reliable parameters of the left atrium size, and should not be reported in our echo report, with only one single exemption, that is in a patient with hypertrophic cardiomyopathy, because as you should know, the diameter of the left atrium enters into the different parameters that are used to calculate the risk score of a sudden death in those patients, a score that has been repeatedly validated by several studies. Another major changes that occurred in the 2015 guidelines was the change of the threshold values to define and enlarge the left atrial volume. In the previous guidelines, it was 28 millimeters meter squared, but now, in the meantime, between the two editions, between 2006 and 2015, several observational studies that included several thousands of patients with and without any history of atrial fibrillation or valvular disease demonstrated that there is an increased risk of death, heart failure, atrial fibrillation, and ischemic stroke when the left atrial maximal volume index increased more than 34 millimeters per meter square. And this has become the new threshold to define an enlarged left atrium. So we needed to measure the volume, and we needed to measure it well, because even a few millimeters of difference that change the classification of the patients in mild, moderate, or severely dilated left atrium changes its prognosis and its risk profile. So the normal values that were up to 28 changes to 34, and then the new classification defined the mildly dilated left atrium between 35 and 41 millimeters meter square, moderately dilated 42, 48, and severely dilated when it's larger than 48 milliliters meter square. As you see, few millimeters of difference dramatically change the classification of our patients. Something that we paid attention is that few milliliters is also the difference when in the same patients you use either the disks summation algorithm, so the Simpson algorithm, or the area length. You see that in the same patients here, we have a trim with a normal left atrium. You have a 3 milliliter of difference. Well, this 3 milliliter of difference, when indexed by the body surface area, made the difference because with the Simpson, this is a normal atrium, and with the area length is a mildly dilated left atrium. So one of our fellows was interested in that, looking at how the use of the two algorithms can change the classification of the patients, and made this exercise comparing the classification of almost 500 patients, consecutive patients coming in the echo lab, when you use the old chamber quantification threshold value of 28 and so on, the new threshold values calculated with the Simpson rule or the area length. And you see that there is a dramatic change in the classification of the patient. The most dramatic of them is from the just changing the threshold values that were dramatically overestimating the number of patients with an enlarged ventricle. You see that the number of normal left atrium almost doubles when we just change the threshold values from 28 to 34 milliliters meter square. But also, when you compare using the same threshold values, the two algorithms, there are significant differences. Just to summarize, with from the threshold used in 2005 and the threshold values for normality and used in 2015, we changed the classification of almost half of our patients, but also using the two different algorithms was not negligible, because 20% changed their classification. Particularly, there are less patients with the normal left atrium, and of course, more patients with the severe, moderately, or severely dilated left atrium, with all the implications in terms of prognosis and even of treatment. However, the good news is that looking at the outcome of our patients, either using the area length or the Simpson method, doesn't change your ability to predict the all-cause mortality or even the cardiac mortality. So this is not a major issue. But once again, what is good by the new classification is that we are able to stratify the risk in patients with the moderate or even a mild left atrial enlargement that were all grouped together using the threshold values used in the 2005 version of the cardiac chamber quantification. Another issue, and this is more technical in the measurement of the left atrium, is the view you used to make the calculation by 2D echocardiography. Because usually we noted that the left atrium is measured by the same view, the same four-chamber view that you use to measure the left ventricular volumes. So this is a view where is optimized for the left ventricle, and so you search for the maximal length of the ventricle. But this, we realized by using a 3D echocardiography that this is a big mistake, because the long axis of the left ventricle that you see in this animation is not on the same plane of the long axis of the left atrium. So when you optimize for the left ventricular length, you necessarily foreshorten the left atrium. And when you optimize for the left atrial length, you foreshorten the left ventricle. So using the four-chamber view optimized for the left ventricle necessarily portends for an underestimation of the size of the left atrium. And here you see, using these three cut planes obtained from the same 3D data set, you have an idea of how the long axis of the left ventricle in the four-chamber, in the two-chamber, and in the long axis can deviate in the direction from the long axis of the left atrium, and you realize how much you will foreshorten one of the two chambers when you optimize the length for the other. This was also demonstrated elegantly by this study by Iwataki and co-workers that showed that when they used the four-chamber and the two-chamber view optimized from the 3D data set, they were able to reduce the difference between the volumes calculated with the two-dimensional biplane method and those measured by the 3D data set. You see that with the conventional biplane, it was quite a large limits of agreement. When you use the 3D derived biplanes oriented to the left atrium, the limits of agreement are much narrower. However, even when you optimize for the length of the left atrium in a four-chamber and in two-chamber, your calculation almost always results in underestimation of the left atrial volumes when they are measured with cardiac CT or CMR. So we need to move a step further, and the step needed to have an accurate measurement of the left atrium is a 3D echocardiography. And similarly to what happens for the left ventricle, the right ventricle, also for the left atrium, when you measure them with the 3D echocardiography without any geometrical assumption about the shape of the left atrium, you will invariably obtain larger left atrium than those calculated with 2D. So when you measure 3D echocardiography with the 3D, you expect a higher accuracy, and we will see how close the measurements are when compared to reference imaging modalities like CMR. You have an increased reproducibility also provided by the fact that those software packages are largely semi-automated for the identification of the endocardial border, and there is no foreshortening of the left atrium. The temporal resolution is quite good, particularly compared with the other imaging modality. And not only you will have the maximal volume of the atrium, but you can also automatically measure the other phasic volumes, and particularly the volumes pre-A and the minimum volume that we will see have a strong prognostic value. Does it matter? Do you have to spend time to obtain the 3D volumes of the left atrium? Yes, the answer is yes. This has been demonstrated in several studies, and we present just a couple of them. The first one is patients with a dilated cardiomyopathy with severe right ventricular dysfunction, all patients in a sinus rhythm, and they were evaluated for death or rehospitalization for heart failure with a mean follow-up of 10 months. And you see that having a maximal left atrial volume larger or smaller than 100 milliliters makes a difference in your event-free survival. And what they found was the maximal left atrial volume in 3D and age, but not the maximal volume calculated with the 2D, were independent predictors of events in this population. And particularly, the maximal volume measured by 3D had a significantly larger area under the curve than the maximal volume measured with the 2D in predicting the prognosis of those patients. The problem with the 2D, as we discussed before, are not only the long axis orientation that is frequently parallel to the left atrium, but also the geometrical assumption that the left atrium is a rotational ellipsoid shape. This is not, and this is easily seen when you look at the 3D data set. Sorry for that. And you see here that particularly the anterior-posterior dimension is the smallest between the two. And so just taking the 4-chamber and the 2-chamber make an erroneous assessment of the true geometry of the left atrium. With 3D, you don't have these problems because the measurement is done without any assumption about the shape of the left atrium. You make a planimetry of the endocardium of the left atrium and then reconstruct this green sac that is called a boitel, and the volume is just the count of the voxels that are included into the boitel. So there is an actual measurement of the volume of the left atrium and not calculations anymore. As I told you, you don't only add the maximal volume, but you can also have two other important volumes. That is the volume pre-A, so before the contraction of the left atrium in a patient with a sinus rhythm, and particularly the minimum volume, so the end at the end diastole of the left ventricle. That it's very important for the calculation of the functional parameters of the left atrial phasic function. Indeed, the function of the atria that has been reevaluated in the last years is really important. First of all, we have a physiological change in the function of the left atrium. And not only because age is associated with an enlargement of the volumes, but also the way the left atrium function changes with the aging, and the active contribution of the left atrium during the contraction after the P wave increases from 26% of the total left atrial stroke volume in subjects younger than 30 years to more than 35% in subjects older than 50 years. While the total emptying volume is not age-related, it's just a change in the function, but not in the overall output. And this is one of the first paper by Russo and co-workers published in JACC Imaging in 2017. This is a community cohort of more than 700 patients with the cardiovascular risk factors, looking at the prediction of atrial fibrillation, death, and myocardial infarction. And you see that all indexes of left atrial size, maximal volume, and particularly minimum volume were related to the prognosis. And you see that the difference between those event-free and those with events is much larger for the minimum volume than for the maximal volume. But also the function, the emptying fraction and the left atrial emptying index were all related with the outcome. This is another interesting study by Wu and co-workers in patients with mitral valve disease, and you see that they compared the prognostic value against MAC of 2D calculations of the volumes of the left ventricle with the 3D measurements of the volumes. So compared with the model 0, where there are clinical variables, adding the left ventricular ejection fraction, of course, increases your prediction of the outcome. And also, it increases the prediction of the outcome when you add to the clinical variables and left ventricular ejection fraction, also the calculation of the maximal left atrial volume, while the 2D minimal volume doesn't change the prediction power. This doesn't happen with the 3D echocardiography, where you have the same behavior comparing the clinical variables with the left ventricular ejection fraction, the 3D left atrial maximal volume, but you see that on the top of them, adding also the minimum volume measured with the 3D echocardiography significantly increases the predictive value. So 3D echo is a powerful prognostic indicator of the left atrial volume, and it is also very accurate compared with the CMR. The first study validating the 3D echo with the CMR was this one made by the University of Chicago. The first author was Victor Moravi, 100 patients with a wide range of left atrial sizes that were measured by 4 different institutions, by 2D echocardiography, 3D, and CMR, and then compared. And you see that compared with the 2D echocardiography, 3D volume are much better correlated with the CMR, but more importantly, they have a zero bias, a bias that minus 30, so an underestimation of 30 milliliters by 2D echo compared to CMR is reduced to 3 milliliter using 3D echocardiography, and also without increasing the level of agreement. But what is particularly important is the agreement with the CMR in defining normal or abnormal the left atrium. You see here, using 2D echocardiography, you find you miss 28 patients who were abnormal by CMR, but the erroneous classification by 3D echocardiography is just 14 patients compared to the 30 with the 2D echocardiography. And of course, your level of agreement quantified by the K index increases from 0.70, that is just good, to excellent with 0.86. Today, we have dedicated quantification tools to measure the left atrium by 3D echocardiography that provides also phasic volumes, so minimum volume, maximal volume, volume pre-A, and all the different function indexes, also showing the time volume course of the change of the volume over the cardiac cycle. And these volumes, and this is a paper that is going, is in press now on the European Art Journal Cardiovascular Imaging, are very, very accurate. You see the level of agreement with CMR with the bias of 2 milliliters and the level of agreement of plus minus 9 milliliters. Also, Philips has its own software for the fully automated measurement of the left atrial volume throughout the cardiac cycles with the ART model. And recently, this has been validated by this study by Italiano and co-workers, showing that compared with the 2D the heart model with the 2D echocardiography with a quite large bias and quite large limits of agreement when you have the difference with the CMR of the heart model is much lower with a bias of 9 milliliters and limits of agreement of 38. So since 3D echo measures larger volumes than 2D, we needed to have specific reference limits, and they were produced by several of us. We were a part of this game, and in 2015 we measured 3D left atrial phasic volumes in 300 patients, 300 healthy volunteers using 2D and 3D, and as expected, we found that the normal limits for normality are slightly different when you use 3D and 2D echo in defining the normality. So the normal limits are not interchangeable. Quite interestingly, recently, the Singh and co-workers on behalf of the World Alliance of Scientific Society of Echo Investigators made the same exercise in closer to 1,800 subjects and found very similar volumes to what we have found in a much smaller cohort, and always the same difference between the 2D and 3D, with the underestimation of the volumes of the left atrium, even in normal subjects by 2D echocardiography. Just a few words for finish, that size is just one of the characteristics of the left atrium, but also function. It's really important. And if the volume and the emptying fraction are a function of the chamber, now we have with echo the opportunity with the speckle tracking echocardiography to study also the function of the wall of the left atrium, the myocardium of the left atrium. And this is really important because you see, for example, in these three patients, that they have strikingly different reservoir longitudinal strain. This is 37, 29, and 7%. And just despite the size of the left atrium in these diseased patients is quite similar, 50 and 49, but the longitudinal strain is slightly different. And the difference is because of the pathophysiology of the enlargement of the atrium. In the one with the normal left longitudinal strain is just a severe mitral regurgitation due to prolapse of the mitral valve. The other one is a patient with infiltrative disease, amyloidosis. And the longitudinal strain is becoming more and more important parameter to describe the left atrial myocardial in deformation, and has been demonstrated quite a useful predictor of death or need for heart transplantation in patients with heart failure with reduced ejection fraction. Has been shown to be predictive of the likelihood of left atrial reverse remodeling and maintenance of the sinus rhythm after catheter ablation of atrial fibrillation. And also, when it is the function is associated with the size, increase the accuracy of the CHAS score to predict mortality and future hospitalization for cardiac causes in patients with atrial fibrillation. Oh, sorry, I have a problem with the computer. Oh gosh. Let me check what's happening. Oh, Okay, however, I had just a few study showing this concept, but I think that the time is going to end, and I can just stop the presentation here if to leave space for questions. Sorry for the problem with the computer.
It appears that that we've got a little bit of time for questions and discussion. Just by way of historical interest, Dr. Badano spent some time comparing the 2005 and 2015 guidelines that the American and European societies produced, and it's interesting to me for historical reference. The 2005 guideline was one that was published before I became editor of JACE. And in going back and looking carefully at it, the differences that you discussed and demonstrated so convincingly, I think have partially to do, and perhaps more than partially to do, with an interesting quirk of mathematics. If you look carefully at the table in that document, and you showed this in one of your early slides, Luigi, the normal value was established as because in normal individuals, the dimension measurement was 22 plus or minus 6. And what was used to determine the upper limit of normal was mean plus 1 standard deviation, which is not mathematically typical. So if you used mean plus or minus 2 standard deviations, the upper limit would have been 34, which is exactly what the 2015 document demonstrated. So I think what I think all of this shows, and what your discussion demonstrated pretty elegantly, is that the left atrium is more complicated in shape than we've given it credit for, and that if we use imaging methods that are orientation dependent, we're going to measure depending on where we've imaged from. And I think from my standpoint, you've made a pretty strong argument, and I think you mentioned this early on, that measuring atrial size using M-mode or 2D is probably not terribly valuable, and that what we should be doing routinely is using 3-dimensional echo so that we're imaging the chamber without making shape estimates and without dependence on where we've imaged from. Do you think that's an accurate assessment?
Yes, as I told before, with one single exception, that are patients with hypertrophic cardiomyopathy, where the anteroposterior diameter enters into the score for estimating the risk of sudden death of those patients. There is no point to use a linear dimension, particularly the anteroposterior diameter, to estimate the left atrial size anymore.
Other questions for Professor Badano?
Hi, can you hear me?
Absolutely.
Yes.
Hi, my name is Young Kwon from Harvard Review. Great to be able to hear your talk, Dr. Badano. I don't know whether this computer problem is going to be going on for the rest of the meeting or not, but I'm very curious to hear when I came in contact with this concept early on about this functional assessment of left atrium, and I don't know exactly where your talk was going to go from here. I know we've been talking about mostly volume assessment, but two questions always come up to me, which is that first is what is the implication of left atrial function, or even perhaps size, in the presence of diastolic dysfunction of the left ventricle, because it's tightly coupled to it. So I just wanted to hear just your thoughts, how it's correlating each other. The second is the reliability part of the left atrial size or even functional assessment. Right atrium for sure is very sensitive to volume at the time of measurement. Left atrium, to some extent, I would guess that there's some of that component as well. And I work a lot in the ICU, and I do try to make some measurement on my own as poor man's measurement. But in the acute care settings where the volume status change rapidly from time to time, I always wonder whether I can use that as an assessment for general assessment of somebody's left atrial size versus measurement that's done in the more ambulatory settings and that we use for prediction of future outcomes and et cetera. So just wanted to hear some overview on these aspects.
Okay, thank you for those excellent questions. So if I correctly understood, the first one is about the relationship of left ventricular systolic function and left atrial function in patients with diastolic dysfunction. Is this correct?
Yes. So left LV diastolic function. So
yeah.
Left ventricular diastolic function and left atrial function.
Okay.
Or even left atrial size. Yeah.
We have in a clinical practice, you have always encountered patients that using the current algorithm that has been issued by the American Society of Echo and the European Association of Cardiovascular Imaging, you end up in 15-20% of your patients with undeterminate diastolic function, because one or the other of the key elements, the left atrium size, the tricuspid velocity, the EA or the E prime, are not reliably measurements or cannot be measured. So in those patients, being able to measure the reservoir component of the left atrial function has been shown to be key in the correct classification of those patients. There are a couple of papers produced by the lab in Chicago by Dr. Singh that have shown that the assessment of the left atrial reservoir function by itself outperform the complex calculation of the left ventricular diastolic function in classifying patients with left atrial mean pressure higher or lower than 12 millimeters of mercury. And there are also many other studies that have shown the accuracy of measuring the strain. And when the left atrial strain is below 20 or below 18, as has been proposed by the latest guidelines for the diagnosis of heart failure preserved ejection fraction by European Association of Cardiovascular Imaging, this is a strong marker that the patients can have increased pressure and indeed left ventricular diastolic dysfunction. On the other hand, about the loading dependence of the parameters of left atrial function, this is true. Is not as strong as on the right side, as you have correctly underlined. But what has been noted that the function of the left atrium takes time to remodel, even after sudden changes of loading, like filling the patients with saline quite rapidly or diuretizing your patient. You don't have these sudden changes as you have in the tricuspid regurgitation, maximal velocity, or the size of the right atrium, but both the size and also the function of the left atrium are much slower to adapt to the changing of the loading conditions. So giving you the time to assess the function of the left atrium, even if the patient has changes his volemic state. I don't know if I have answered your questions.
Luigi, let me ask another two questions actually on behalf of David Linker, who sent these in via chat. The first is, can you comment on using the time course of atrial volume or strain to assess left atrial function?
Yes, we have seen that, of course, there is a strong relationship of the reservoir phase of the left atrial function with the shortening of the long axis of the left ventricle. So the motion of the mitral annulus towards the apex. So these two are heavily dependent, and indeed, even if the left atrial adds in terms of prognosis to the assessment of the longitudinal function of the left ventricle, the addition is quite small. But indeed, the contraction phase of the left atrial function, so the shortening of the myocardium after the P wave, this is an independent predictor of a prognosis in many conditions, and both in patients with, and in particularly, of course, only in patients in sinus rhythm.
David, do you want to add to that? You just added something about pump function. You might expand on that.
Well, no, the answer was excellent. That was exactly it. My point was that it seems that atrial strain is often looked at as a single number, but we have a phasic change. We have the reservoir function, we have the pump function, and analyzing those separately seems to be a fruitful area to explore.
Good. And then since you sent this in, I'll ask your second question, David, which is there a better, and it's an interesting question that doesn't apply, I think, just to the left atrium, but is there a better method for normalizing than using body surface area? Because that's going to influence the result in patients that are quite large or not quite large. And there's been a fair amount of debate, I think, in the literature about different methods for normalizing. Luigi, can you expand on that?
Oh, that's really an excellent question. Indeed, the attempt to normalize the strain is not with the body surface area, but is with the volume of the left atrium. So it seems that the same amount of strain in a larger volume is less serious than having the same strain in a smaller atrium. So in some way, the length of the endocardium affects the final results and the prognostic power of the strain. But those are just preliminary data, and I don't have any definitive answer. I don't know if anyone in the University of Washington have different experience.
I was actually wondering about left atrial volume and normalizing left atrial volume.
Yes, this is another issue, particularly in obese patients. However, I am not aware of any better way that has been solidly demonstrated. There are attempts to normalize for the height of the patients with the different exponents but I cannot refer any study that has compared the predictive power of the two way of normalizing and found significant differences.
My recollection from the literature, and I'm certainly not an expert in this area, but for the fellows, my recollection is that there've been, the concern is that what you'd like to normalize for is lean body mass, and certainly in obese patients, a measurement of weight doesn't show that. So there have been methods that have been proposed and tested for the left ventricle, at least using different height measures and height to different exponents, et cetera. I'm not sure that I've seen data on the left atrium. And again, if we had a practical method to look at lean body or to determine lean body mass in individual patients, it can be done, but it's not straightforward. We'd use lean body mass, I think. Okay, other questions or comments? Not sure if Dr. Kirkpatrick is still lurking in the background or has anything else to add.
I'm always lurking in the background.
That's
Absolutely.
what I thought.
That was a fabulous discussion, and I really appreciate sort of highlighting the differences between what we currently do in measuring both the left atrial size and also the idea that the speckle tracking strain should be, or maybe soon, fully incorporated, not just in the European guidelines, but in many guidelines, into the assessment of diastolic dysfunction, and may in fact be a way that would supplant the other markers, which are, to say the least, somewhat cumbersome. I guess the question that I would have for you, Luigi, is to what extent do you think that this will be easily disseminated among echo labs all over the place? And obviously the strain software is becoming more available to everyone, but there is an associated cost, and there are some concerns, I think, on the part of particularly smaller echo labs that they'll be able to basically start doing these things that are superior, but maybe a little bit more cumbersome to do. And I know there's probably some concerns too about how much time it would take. I wonder if you could address the practical application or dissemination.
I am so sorry that the presentation has crashed at this moment, because one of my last slides was just about an idea that we had with the GE representatives. So to provide the automated calculation of the volumes of the left atrium when you trace the region of interest for the strain. So with one single, just with 2-3 points, and you don't trace the endocardium, and you have both the strain and the volume just to address the workflow. And indeed, and the paper is already available, but not or available on PubMed, but not published on the European Journal of Cardiovascular Imaging. The automated volume that you can obtain after traced the region of interest for the strain is at least as accurate as the 2D calculation used with the biplane Simpson's rule. Of course, underestimates the 3D and the CMR volumes, but is at least as accurate as your conventional 2D calculations. And I think that this is the way to try to integrate the different measurements to provide multiple parameters in order to streamline the workflow in the Echo Lab. Unfortunately, this is just for one vendor, but you know, the idea that easily spread across the different vendors.
I think
That's excellent. Thank you.
I think David Linker will remember the early days when there was a lot of discussion about why would you ever need to use two-dimensional echo as a routine? Is an M mode sufficient? We moved well beyond that. I think why use 3D echo is a discussion that will probably fade. And my suspicion is Dr. Badano just demonstrated, that the machines over time get pretty smart, and automated edge detection, while you could argue is subject to some errors, is also pivots on one of the major strengths of echo that we don't talk about enough, which is the ability to use this for serial estimations or serial evaluations in an individual patient, where the reproducibility becomes at least as important, if not more, than the accuracy. And when we do this with software, at least the methodology is the same, independent of who's doing the analysis. So I think we'll see this down the road. Anyway, I suspect we're probably up in terms of time. People have clinical commitments. And so I'd like to close, unless Jim has further comments, to thank Professor Badano for a very interesting discussion of a topic that we probably haven't focused enough upon, but now have methods to do that. And again, I'm delighted that the Drays were able to attend and test drive some of their Italian and enjoy this lecture with us. Thanks very much, everyone.
Yeah, I'll just add
you.
my thanks
Thank
also.
you.
And
Ciao.
okay, thanks again, Luigi. Luigi, we should give you the last word, because we appreciate so much you joining us today and the Drays in sponsoring this.
Thank you. Thank you very much. Indeed, it was really nice, and also very nice discussion. Thank you.
Grazie, Luigi.
Ciao.
Ciao, ciao.